Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Pathak, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. Bipolar disorder is a condition that many of us have heard of, but it's often misunderstood. In this episode, we'll explore what distinguishes bipolar disorder from unipolar depression and why identifying mania or hypomania is crucial to getting the right treatment. We'll also explore the biologic underpinnings that make someone vulnerable to bipolar disorder in the first place, and why routine and even something as simple as going to bed at the same time each night can become a powerful tool for mood stabilization. Most importantly, we'll learn about the therapies, both medical and behavioral, that can stabilize mood, build resilience, and allow people with bipolar disorder to live life on their own terms. If you or someone you know has been diagnosed with bipolar disorder, you won't want to miss this conversation. First, let me introduce my guest, Dr. Holly Swartz. Holly Swartz is a professor of psychiatry at the University of Pittsburgh School of Medicine. Dr. Swartz's research focuses on understanding and optimizing treatments for mood disorders. She's well known for her work evaluating interpersonal psychotherapy, IPT, and interpersonal and social rhythm therapy, IPSRT, as treatments for depression and bipolar disorder. She's currently the president for the International Society for Bipolar Disorders. Welcome to the WebMD Health Discovered podcast, Dr. Swartz.
Thank you so much for inviting me.
I'm very excited to jump into our conversation today. But before we do, I'd love to invite you to share with us your own personal health discovery, your aha moment around bipolar disorder and the work that you do.
I'm particularly interested in the effects of circadian rhythms on individuals at risk for and experiencing mood disorders. And for the past couple of decades, I've had the opportunity to work with a behavioral intervention for bipolar disorder, interpersonal and social rhythm therapy, to address some of the behavioral aspects of circadian dysregulation in bipolar disorder. And so I think for me, it's been a growing awareness of the importance of circadian dysregulation in bipolar disorder, both from an etiologic standpoint, so, a causal framework, as well as a manifestation of the illness itself. I've been just really excited to work with colleagues to hone an intervention that can be put in the hands of people who wish to use it to regulate their behaviors in order to stabilize underlying disturbances in their circadian rhythms. So the evidence is growing, and it's really exciting to see some neurologic correlates for this intervention and also working to disseminate it globally. So it's just a really exciting time to be able to develop and test a tool and get it into the hands of people who are finding it to be useful.
Wonderful. So before we do, let's just take a step back and define bipolar disorder for our listeners.
So, bipolar disorder is definitionally operationalized by diagnostic criteria. Typically, in the United States, we use the DSM, the Diagnostic and Statistical Manual Criteria. We're currently on the fifth version of that, of the DSM 5, to define what is bipolar disorder. So, it's at this point a clustering of symptoms. So, there's different types of bipolar disorder. There's bipolar 1 disorder, there's bipolar 2 disorder, there's bipolar other specified disorder, and some other ones that are maybe somewhat less common and less well operationalized. But the way that we define bipolar 1 disorder is at least one episode of mania. And often folks also have episodes of depression, but it's not required for us to make the diagnosis. For bipolar 2 disorder, all that is required is one episode of hypomania. So hypo meaning lower than or less than mania. And we can talk about how you distinguish between mania and hypomania, plus at least one depressive episode. So the definitions are set forth by the DSM, and that's what we use to make formal diagnoses of bipolar disorder.
Well, that's really helpful. And March 30th is World Bipolar Day. and really critical in terms of raising awareness and destigmatizing what people commonly think of as bipolar disorder or someone with bipolar disorder. Can you talk a little bit about why understanding what bipolar disorder is and destigmatizing our understanding of what it is, who the types of people that have bipolar disorder is so important?
Yes, thank you for acknowledging World Bipolar Day. So that the date was actually chosen in honor of the birthday of Vincent van Gogh, who obviously is a very renowned artist who is thought to probably have had bipolar disorder. I am part of the International Society for Bipolar Disorders, and we sponsored the World Bipolar Day. And we've been, for the last couple of years, observing it really for the month of March rather than just one day, because we think it's a really important issue. And we do want to raise awareness about bipolar disorder. And as you said, reduce stigma and support individuals living with bipolar disorder. I think it's really important that we undertake this mission because bipolar disorder, like any medical illness, is not the person's fault. It's not a weakness. We're all dealt a biologic hand, and some of us are dealt a biologic vulnerability to asthma or to high blood pressure or to diabetes. And some people are dealt a biologic hand that predisposes them to bipolar disorder. And unfortunately, in many cultures, in many settings, the illnesses that affect the brain are stigmatized, really, in my mind, inappropriately to other medical illnesses. But this is just another medical illness like any other medical illness. And like most medical illnesses, there's an interaction between your underlying biologic vulnerability and the environment. So if you've got that biologic vulnerability, say to asthma, and you go rolling around in a hayfield, you're going to have an exacerbation of your asthma. So same thing with bipolar disorder. It's a biologic illness, but it can be improved or exacerbated by environmental contexts. And so it's really important to support those living with bipolar disorder by speaking out and informing, educating the community at large about what this is and helping accept the fact that these are just one of many illnesses that affect our population.
And to your point about educating people about what it is, you mentioned hypomania and mania, two terms that can help define or identify whether one might have bipolar 1 or bipolar 2. So, can you talk a little bit about those terms?
There's a lot of similarities between hypomania and mania, but hypomania is sort of a less intense version of mania. We would recognize mania when somebody's experiencing at least 1 week of either elevated or irritable mood every day for most of the days. So it's not just like a little blip, for an hour here or an hour there. And it's accompanied by a bunch of other symptoms like decreased need for sleep. A lot of people are more impulsive, making decisions that result in negative consequences like overspending or sexual indiscretions. People who are manic are often speaking really fast, their thoughts go really quickly. It may be accompanied by suicidal thoughts. And when some people are manic, they may or may not experience psychotic symptoms. So, starting to have difficulty distinguishing between what's real and not real, maybe hearing voices or feeling paranoid. The diagnostic criteria for hypomania are almost identical with a couple key differences. So, if this episode lands you in the hospital, it is by definition mania, not hypomania. The other sort of criteria that's distinguishing is whether it causes significant impairment. So this is a rather subjective term in my opinion, but basically if you get yourself into real trouble with the mania, then it's mania. And if it's like, yeah, you're up, you're not sleeping as much, you're talking a little fast, maybe you're impulsive, but not really blowing out your bank account or getting arrested for speeding, then it doesn't kind of cross that threshold for mania. It is a bit subjective, though. I accept that fact because it can be sometimes hard to sort out. The other one is that the minimum duration, not the maximum duration, but the minimum duration for symptoms for hypomania is 4 days versus 1 week in mania. If it goes on for 3 weeks, a month, that doesn't tell us anything one way or the other, but the hypomanic episodes are allowed to be a little bit shorter than the manic episodes in terms of duration.
Can you talk to us a little bit about the depression side of it? And is it different from major depressive disorder?
That's a really important question. So, major depressive episodes are identical in those three disorders. and I can talk about what we look for a major depressive episode, but what we see in major depressive disorder, in bipolar 1 disorder, and in bipolar 2 disorder, the criteria are identical. So, cross sectionally, if you go into a doctor's office in the midst of a major depressive episode, the doctor can't tell if it's bipolar 1 disorder, bipolar 2 disorder, or major depressive disorder unless they ask questions about your history, because that's really what determines the diagnosis. So this can be really confusing to people because the depressions themselves are pretty much the same in all of these three disorders. So our duration criteria is 2 weeks for depression. So at least 2 weeks of feeling down, having lower interest in things nearly every day, most of the day, and then accompanied by a bunch of symptoms, which in my mind are the opposite of mania. So you can either have more sleep or less sleep in depression, but for folks with bipolar disorder, it's actually usually the more sleep version of this. It can affect your appetite, having decreased or increased appetite, feeling hopeless, feeling slowed down, often accompanied by suicidal thoughts. So these are some of the symptoms that are required in addition to low mood to make a diagnosis of a major depressive episode. And it is, as I said, the same across those disorders, although there's some clues that help us that might suggest that the episode is related to bipolar disorder versus major depressive disorder, which we also call unipolar disorder because it's just one pole, just the depression, not the bipolar disorder, both sides of the mood dysregulation. And those would be things, as I said, like during the depressive episodes, having increased sleep, increased appetite, really feeling slowed down. Those are some clues that we sometimes look for. It's not an absolute slam dunk way to differentiate from the different disorder types, but these kinds of what we call reverse neurovegetative symptoms, that's what those things are called, help us maybe have a clue as to whether this is bipolar disorder or a unipolar disorder.
So I just want to take another step back and come back to something that you were talking about with regard to what might be stressors, environmental, or experiences in your life that, with that biologic susceptibility, may sort of cause or trigger or worsen your bipolar disorder. So, can you talk a little bit about what those are?
So, I mean, life stress, bad things happening in your life, trauma, all those things can predispose you to a bipolar episode if you have bipolar disorder. Other common triggering factors include substance use. So, cannabis products are notorious for triggering episodes in individuals vulnerable for bipolar disorder. Also, some prescribed medications can sometimes trigger episodes, like stimulants, for instance, or selective serotonin reuptake inhibitors. And then what I call chronodisruptors. So, things that disrupt your daily rhythms and routines. So, not getting enough sleep, traveling across time zones, switches in the clock from standard time to daylight savings time. So things that mess with your routine schedules and circadian rhythms.
And can you talk a little bit about lifespan triggers? Is there a particular age where the prevalence is more common? Is there a particular time period? Are there certain changes that happen in life where you might see more quiescence of these symptoms? Can you talk across the lifespan of where you see bipolar diagnoses emerging more commonly?
The average age of onset of bipolar disorder is late adolescence, early adulthood. So, somewhere in the late teens, early 20s is the most common age at which these illnesses emerge. We do diagnose bipolar disorder in children. I'm an adult psychiatrist, not a child and adolescent psychiatrist, but my colleagues who specialize in care of children do diagnose kids and certainly adolescents. We also see it persisting throughout the lifespan. This is a chronic recurrent illness, so it does not go away. It might look a little bit different depending on one's stage of life and one's circumstances. We do know that for women at hormonal transitions, those are periods of not infrequently of worsening of mood symptoms or vulnerability. So, especially in the postpartum period, in the menopausal transition, those seem to be periods of risk. But this is a lifespan illness, and individuals with bipolar disorder, once it's been diagnosed, continue to be at risk chronically.
So let's talk now about treatment options. So you mentioned that treatment is going to be different for unipolar depression versus for bipolar. So, talk to us a little bit about how you approach treatment in a step by step way.
The mainstay of treatment for bipolar disorder is what we call mood stabilizers. So the idea is we want to help people stay stable from below and above. So we want to prevent depressive episodes and prevent manic or hypomanic episodes. So we want something that ideally is targeting both poles of the disorder. So our the gold standard for bipolar disorder is lithium. Lithium is a treatment that was discovered in the 1950s and continues to be our first line treatment for both bipolar 1 and bipolar 2 disorder because it has both antidepressant and anti-manic effects. And some people do really well with lithium alone, and that's always actually a good prognosis. There are also a whole host of other medications that we can use to stabilize mood. The one that is often thought of as a second line treatment is valproic acid. That also is a medication that has been shown particularly to have anti-manic properties and to some extent antidepressant properties. There's, I would say, growing concerns about using valproic acid because in women of childbearing years, it has significant teratogenicity. It is not safe to use in pregnancy. And there's actually emerging evidence that it can reduce male fertility and also result in abnormalities in offspring of men who are taking valproic acid. So there is a growing reluctance, honestly, to use valproate as new data is emerging about safety concerns. But from an efficacy standpoint, it does work. So the next category of medications that we often use are what are technically called second generation antipsychotics. Not everybody with bipolar disorder has psychosis. Some people do, but they also have mood stabilizing properties. And so these are medicines like aripiprazole or quetiapine or lorazepam or cariprazine, lumateperone. I mean, there's a whole bunch of them on the market. And the tricky thing about those atypical antipsychotics, some of them have been well tested in mania, some of them have been well tested in depression. A few of them have been tested as maintenance strategies. So there's a little bit of shuffling that we do or sort of calculating that we do depending on sort of the predominant mood polarity, whether somebody's mostly manic or mostly depressed or in a depressive episode. That might point us to select one or another of those compounds based on the evidence supporting their efficacy in a specific mood state.
I'd love to then go back to how we opened our conversation, really talking about your work with interpersonal and social rhythm therapy. Can you talk a little bit about how that works? What are you really targeting? What are you doing? And I imagine you're using this approach in conjunction with medications.
Yeah, we're typically using it in conjunction with medication. So medications are really important. They can really help people and improve outcomes. But the truth of the matter is, even with kind of the best treatment available, over a bunch of years, 2, 3 years, upwards of 40% of people still have syndromal mood episodes despite good treatment. And even individuals who don't have full on episodes can have subthreshold mood symptoms even during inter-episode periods. And so medication is hugely important. And I don't want to in any way dismiss the importance of medication, but it doesn't solve all the problems associated with bipolar disorder. It doesn't allow for complete stability of mood. And it doesn't in any way really address the sort of environmental context that people struggle with that can precipitate mood episodes or the fallout from mood episodes that people experience. And so I'm really interested in the role of bipolar specific psychotherapies to hasten recovery from episodes, to help prevent recurrences, and to address the psychological, psychosocial sequelae of the illness. And the area that I've been working in, as you mentioned, is interpersonal and social rhythm therapy, which is one of a couple of evidence-based treatments for bipolar disorder. And the treatment that I'm talking about, interpersonal and social rhythm therapy, has two components: an interpersonal component, the interpersonal part, and then the social rhythm therapy, which is directly targeting the circadian system. And we've also administered the SRT, social rhythm therapy part, as a standalone treatment. And so some of our more recent work is focused on just the social rhythm therapy part. But the intervention, as it was originally developed and tested, combines both the interpersonal part and the social rhythm therapy part to target these various aspects of bipolar disorder.
So, talk to us a little bit about what this entails. So, what would a session look like with regard to this type of therapy?
So the interpersonal therapy part of it actually is a treatment that's also used for unipolar depression and has very good evidence as a treatment for unipolar depression. And we sort of import that more or less wholesale for bipolar disorder, often using that to target the depressive phase of the disorder. The social rhythm therapy part of it, I think, is what's novel. It's a behavioral intervention that helps people develop regular daily routines in order to stabilize circadian dysregulation. And so it's very focused on monitoring and modifying schedules and routines. We pay a lot of attention to the sleep wake cycle, which is a really important circadian rhythm, helping people learn to get up at the same time every day, even on the weekends, also to go to bed at the same time every day. But we also focus on other important circadian inputs, for instance, meal times, which has an important feedback mechanism to the brain where the main body clock is located. So it's located in the central part of the brain, the suprachiasmatic nucleus. So regulating meal times, but also regulating things like the time that you start your daily activities, the time that you have contact with people. And so we monitor a bunch of dimensions of routines, help people see the relationship between regularity or irregularity of routines and daily mood and energy ratings, and then work with them systematically to improve the regularity of those routines, which is associated with, better mood and better outcomes.
Really, really interesting. So, are there many trained therapists that are accessible to people with bipolar disorder that practice this type of treatment approach?
We're doing our best. We do have an online free training website. It's IPSRT.org. It's free to anybody, and a lot of people have accessed that. I recently published a book called the Social Rhythm Therapy Workbook for Bipolar Disorders. That was partly because I wanted to have a way of getting this out to people who couldn't access a therapist. So it's completely self guided. People can go through the exercises that allow them to monitor and modify their daily routines, or they can do it by themselves or they can use it with a therapist. It's being used in both ways. And we're working hard to train and certify therapists, but it's not easy. It's a big world out there, but we're doing our best.
Yeah, that's really helpful, and I think we'll make sure that the link to the website you mentioned is in our show notes as well, so people can access it there. I mentioned that I'm primary care, do a lot of work in lifestyle medicine. Thinking about your upcoming conference, American Psychiatric Association is going to have a big focus on lifestyle psychiatry. You mentioned regular times of meals. Is there also any evidence or data around types of meals, types of foods, the types of physical activity, et cetera, that have some evidence in terms of also being helpful and beneficial?
Yeah, I will answer that question, but I just want to just take up a moment to mention that circadian dysregulation, as I'm sure you know, has been implicated in a host of medical conditions. So, obesity, other diseases associated with metabolic dysregulation, migraines, cancer, these kinds of lifestyle changes that promote regularity of routines to stabilize circadian rhythms may have applications in a host of medical conditions as well. In terms of specific lifestyle recommendations for bipolar disorder, there's no specific lifestyle strategy that has enough data at this point to fully recommend it. I will say there's some really interesting emerging data on ketogenic diets. There's a bunch of studies that have been published with some pilot data showing preliminary signal for efficacy. It's a hard diet to really adhere to, but there are a bunch of randomized trials underway to see if that might be a strategy for stabilizing mood. I think this is a disorder that's associated with metabolic dysregulation, both related to the medications that we prescribe, as well as to even medication naive individuals have elevated pro-inflammatory markers. And so diets that have been shown to reduce inflammation more generally. So a Mediterranean style diet is part of a general set of recommendations that we can, I think, with confidence make to our folks with bipolar disorder. And same thing, exercise, which helps with weight management and also inflammatory conditions. Any exercise you're going to do is probably going to be helpful. And we certainly think that that's important from a circadian standpoint. Would probably recommend doing it at the same time every day if possible, because that's an important sort of signal also to the brain. But I think whatever people can do to help promote living a general healthy lifestyle is likely to also help some of the risk factors in bipolar disorder.
How do you think about involving others in the social rhythm piece of this in terms of if you're a loved one providing support? Can you talk a little bit about that piece?
Humans are social creatures, so people matter, right? So, from a physiologic standpoint, contact and connections with people matter. From a social support standpoint, this is an illness that can be tough to manage, and having social supports around you to help you when you're having, an episode, to helping you stay on a regular schedule, to help you take your medications. These are all things that can really help people live well with bipolar disorder. There's a big advocacy community out there. So the Depression and Bipolar Support Alliance is probably biggest and most prominent one in the United States. And they run support groups, online support groups. They have a lot of information available for caregivers of individuals with bipolar disorder, as well as for individuals living with bipolar disorder. I've had the opportunity recently to work as a scientific advisor on a documentary that's being produced about bipolar disorder. It's called Brainstorm the Film. That should be out within the year. And there's actually a 16-minute short version of it that's up online. And it really explores the experience of individuals living with bipolar disorder and the challenges that they face and the kinds of strategies that they use to help manage their illness, including, as you suggest, invoking social support to help, get through the illness. So I think there's a lot of information out there, and it's really important for caregivers, for individuals living with bipolar disorder to access those support networks, not only to reduce stigma, which of course is critically important, but also to help people manage their illness and, of course, spread the word about availability of resources.
Can you give us some advice for someone who's newly diagnosed with bipolar disorder in terms of prognosis, in terms of living with the condition, that you want to make sure that our audience understands, something that might help them have that next conversation with their healthcare provider about moving along in this journey? How should someone be thinking about their life moving forward with bipolar?
That's a great question. I mean, I think it's a process. And when any of us get a diagnosis of a chronic medical condition, it's going to require some adaptation for, helping us to optimize our interaction with the medical system and to engage in treatment that's going to promote wellness. But I think the messages that I like to give is that this is a disorder that can be managed, that there are lots of people out there living well with bipolar disorder, that there are a lot of supports for helping people through this journey. And although it can be unnerving to have a new diagnosis of an illness that is going to have to be managed lifelong, the hopeful message is that it's something that can be managed. And more importantly, that you can live well with bipolar disorder. I think it's quite helpful to advocate for yourself and to educate yourself. There are a lot of resources out there. I think a good starting point, as I mentioned, is DBSA, the Depression and Bipolar Support Alliance, for folks who are new. And I think this is really a more message for care providers than for patients. I think this is a collaborative journey. And so there's no one size fits all treatment. Sometimes it takes a couple of different passes to get something that works and that's tolerable. And I think that patients can expect, and I think we as providers should also expect, to work collaboratively to find a regimen that works for you. That's something that you should ask for and should expect. And I think we as providers should facilitate that process by listening, by learning, by collaboratively exploring the newest things that are available, but also the gold standards like lithium that have been shown to work to optimize outcomes for folks who are newly diagnosed, but also people who have been managing and living well with bipolar disorder for a long stretch of time.
Thank you again and again so much for being with us today. I really appreciate you and thankful for our conversation today.
Thank you for inviting me.
There's so many valuable takeaways in our discussion with Dr. Swartz. She guided us through a nuanced look into bipolar disorder, where mood swings aren't just ups and downs, but can be signs of either hypomania or full mania. We explored how stress, disrupted routines, and even seasonal time changes might trigger or exacerbate symptoms. We learned why catching the unique flags of a manic episode, like a decreased need for sleep, risk taking behaviors, and racing thoughts, are key to getting the right treatment, especially since many people are initially diagnosed with unipolar depression or just simply major depressive disorder. We also uncovered the powerful role that stable daily rhythms can play in maintaining mood balance. Consistent wake and sleep times, regular meal time, and mindful attention to how social interactions shape our day can all work alongside medication to help keep symptoms in check. Above all, we discovered that although bipolar disorder is chronic and long term, it's manageable with the right combination of therapies, routines, and open dialogue between a patient and their provider. If any part of today's conversation resonated with you or someone you love, remember there are effective treatments and support networks that can make a real difference in day-to-day life. To find out more information about Dr. Holly Swartz, make sure to check out our show notes, where we'll have a link to isbd.org and also IPSRT.org. That's more information about interpersonal and social rhythm therapy. Thank you so much for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.